Hi, I'm Dr. Jack West, medical oncologist in Seattle, Washington. One of the questions that has emerged and continues to evolve in our thinking is the role for immunotherapy in the subset of patients with advanced non-small cell lung cancer whose tumor harbors a driver mutation, like EGFR mutation or an ALK rearrangement. And for a long time, we've relied just on our anecdotal experiences, perhaps very scant data, and we got some early thoughts on this that I would say now we should be revisiting as we get more information. So let's just take a step back. We know that some patients can have a dramatic and very prolonged benefit from PD-1 or PD-L1 inhibitors, but we saw anecdotally that the patients who had no smoking history or had a driver mutation seemed to be less likely to benefit. And the first real contribution beyond just anecdotal reports was by Dr. Justin Gaynor and colleagues out of Boston, looking at their data retrospectively from 58 patients who were treated with an immune checkpoint inhibitor, and then comparing the results depending on whether patients have a history of smoking or were never smokers, and also whether they were EGFR and ALK wild type or had one of these driver mutations. And what they found was that the patients with a driver mutation especially, and then also the patients who had no smoking history tended to have a lower response rate and a less of a benefit in terms of progression-free survival, as shown in the figure, compared to those patients with a smoking history or who were EGFR and ALK wild type. And this was actually corroborated by the various trials that compared one immune checkpoint inhibitor or another to docetaxel in previously treated patients. And so each of these trials had a forest plot that showed that the patients with an EGFR mutation were the only ones who really didn't have a better result with the immune checkpoint inhibitor. And the data from all of these studies was compiled into a meta-analysis by Drs. Lee and colleagues published this year in JAMA Oncology. And you could see at the top of the forest plot here that for the wild-type patients, EGFR wild-type patients in various trials of immune checkpoint inhibitors versus docetaxel, there is a consistently better progression-free survival in the recipients of the checkpoint inhibitor. In contrast, in the bottom portion of the forest plot, you can see that the EGFR mutation-positive patients do not benefit greater with immunotherapy relative to docetaxel. It's not to say they do significantly worse, but this was actually the only group based on clinical or other variables that Drs. Lee and colleagues found that teased apart as being an independent variable associated with non-benefit from immunotherapy. And so this has really informed our thought process for those of us who are really lung cancer specialists, that the patients with an EGFR mutation, and I would say also even by extension, patients with ALK rearrangements, where we generalize a lot, are just not likely to benefit. And we've largely seen that in clinic. However, we have had some new data emerge that has led some of us to walk back from that early conclusion and feel that that may have been premature to conclude that these patients should definitely not get immunotherapy early and questionably should get it at all. The first piece of evidence we saw that challenges that is from the Empower 150 trial, and I'm showing the figure, the schema here for that, a randomized trial of over 1,200 patients who hadn't received prior chemotherapy and were randomized to either carboplatin paclitaxel bevacizumab as the control arm, arm C on the bottom, or the same chemo with atezolizumab in arm B, or in arm A, a substitution of atezolizumab for bevacizumab. And this trial was presented by Drs. Reck and colleagues at the ESMO Immuno-Oncology Conference in December of 2017, and we learned that there was a clear improvement in progression-free survival for the patients who received atezolizumab on top of chemo and bevacizumab. That's helpful, but we had already seen similar themes. What's interesting about this trial is that it enrolled patients who had an EGFR mutation or an ALK rearrangement, but had received and then progressed on a prior targeted therapy against that driver. And about 14% of the patients in this study fit that description. And from that, we got the interesting result in this forest plot that showed that the patients with an EGFR mutation or ALK rearrangement had the same improvement with atezolizumab relative to chemo and bevacizumab alone that the patients did in the overall trial, and specifically in the wild type. So I have a box around the point that at the top, that the patients with an EGFR mutation or ALK rearrangement had a hazard ratio of 0.59 for progression-free survival compared to 0.62 in the wild-type population, which goes against our general thought process that these patients don't benefit from immunotherapy. It's not clear whether that is because of the combination with chemo, perhaps something about the bevacizumab, but we clearly need to learn more about this. We also got some new information in the form of the Atlantic trial that was published in Lancet Oncology by Drs. Garasino and colleagues. Now, this was a study of durvalumab actually as a third-line or later therapy, and they initially had broader eligibility and then narrowed it to the patients who had 25% or higher PD-L1 expression on their tumors. And it showed activity as you would expect in a pretty broad population, but what was most interesting about this was their inclusion of 111 patients who either had an EGFR mutation or an ALK rearrangement. And what they demonstrated was that there was activity even for durvalumab as monotherapy in these patients. It wasn't as great as we might expect to see with other patients, but it was there. It was greater in the patients with higher PD-L1 expression. In those with less than 25% expression, the response rate was only about 4% versus about 12% for the patients with higher PD-L1 expression of 25%. And there was a reasonable progression-free survival and especially overall survival, even to monotherapy, in the patients at least with a higher PD-L1 expression. But this work also suggested that we might need to be more granular in that there were actually no responses seen among the patients with an ALK rearrangement. They were really just limited to the patients with an EGFR mutation. Also, we're not talking about large amounts of patients just yet, even though we're at least starting to ask the question more intelligently. So what can we say about this? I would say that we need to reconsider the blanket statement that immunotherapy agents do not work for patients with driver mutations. That was seemingly what the converging evidence said based in the second-line trials and a lot of our anecdotal experience where we relegated immunotherapy to a late therapy. But the Empower 150 trial really shows that the patients with the driver mutation seem to get the same degree of benefit from the combination of atezolizumab with chemo and bevacizumab, whether that is because of the combination with the chemo, perhaps the inclusion of the bevacizumab, or both, we need to learn. But this has really been a population of patients who have been excluded from many of these trials, at least in the first 1 or 2 lines of therapy. And it just suggests that we need to explore this question more carefully and that we should really reserve judgment and provide at least the opportunity for these patients to benefit. My personal approach is now more likely to be a combination with chemo. I'm very interested in seeing whether bevacizumab adds to the mix, and we should expect to see more data on these questions in the coming years. So I hope that's interesting, and I welcome your thoughts and comments on this still very open question. I hope you'll like, comment, and subscribe, and I look forward to talking about this and some other related issues in the field in the future.